Good morning, good afternoon, good evening. Welcome, everyone. Ladies, gentlemen, guys, gals, and non binary pals. I'm Monique Springer, Project Officer with UWIHARP, and I'm joined with Keelia Anderson, our Project Assistant. A very special welcome to our students, staff members, colleagues with the National HIV/AIDS Commission, off campus partners, repeat visitors, and to our new guests. UWIHARP is the HIV Sexual Health Unit at UE, and we seek to positively influence the sexual and reproductive health and wellness of the university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as our digital dialogues. These are sexual health conversations and will be held during this semester. They include the S Files discussion series on a wide range of topics and the Shock series, which will focus on sexual health issues among our vulnerable Caribbean populations during COVID. You can look out for our flyers on our social media platforms, which include Facebook, Instagram, the UE app, and through student UE emails. There are a few participating guidelines. All mics are muted and videos are turned off. Q&A will take place after the presentation and the mics will be unmuted. We ask you to post your questions and comments during the presentation in the chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. Alternatively, you can message me directly if you prefer. For those questions we couldn't get to, please email them to uwiharp@cavehill.uwi.edu before the end of the day, and we will address them shortly afterwards. The sessions will be recorded, and the recordings will be posted afterwards on our social media platforms, including our YouTube channel, UWIHARP Cave Hill. These will be done without sensitive personal discussions to protect participants' confidentiality. Please note that we cannot guarantee confidentiality in this public forum among participants, so be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Please complete the evaluation form that will be sent to you after the session, and you can suggest topics that you are interested in for us to facilitate. There are a few rules for participation, and some of them have been adapted from the HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters and or participants. Persons who engage in any such undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP's guiding principle is to first do no harm. And today's topic, as you know, is breast health awareness. And we will be also focusing on learning how to conduct our own self-examinations. And of course, we are joining the global narrative on breast cancer awareness, and which is October month. And we have a very special guest with us, Dr. Shirley Hanneman Jhagroo. Many of you may already know her. She is Barbados' lead advocate for breast cancer awareness. She's Guyanese-born obstetrician and gynecologist, and she received her medical degrees, including postgraduate training in obstetrics and gynecology and colposcopy in Ireland. In 1999, she was one of the pioneers that started the breast cancer awareness and early detection program of the Barbados Cancer Society, where she served as council member from inception and today is the medical coordinator of the breast screening program. Dr. Hanneman Jhagroo won a number of awards for her contributions to medicine in the field of breast cancer awareness. And these include the 2013 Gold Crown of Merit by the Barbados government and the 2017 Health Hero of Barbados Award by WHO PAHO. I now invite Dr. Hanuman Jhagroo to talk to us today about the importance of early screening and detection, and also maybe looking at the contextual situation of breast cancer in Barbados. Thank you, Dr. Jhagroo. Over to you.
Thank you. And certainly it's a pleasure to be here and to share my knowledge. Now, first of all, breast cancer awareness and why so much concern about breast cancer? Why so much about awareness? Breast cancer is the most common cause of death from cancer in Barbadian women, with an average of 1 death per week being recorded in Barbados. And in 2020, at the breast screening program, which is what I'm medical coordinator for, an average of 2 to 3 new cases are being diagnosed per week. In the United States, just for some comparison, breast cancer is still the most common cancer amongst women and is the second most common cause of death in women. In January 2020, it was forecasted that approximately 276,000 new cases of invasive breast cancer will be diagnosed in women during the year, and only 15 to 20% of these will be non-invasive. So about 42,000 persons will also die from it. The incidence, however, is higher in the white population, but the mortality, that is the deaths from that disease, is higher in the Black population. And that is due mainly to late diagnosis, secondary to less availability of resources. Now, in the UK, just for another comparison, it remains the most common cancer in women, but the third most common cause of death. And in places like Belgium and Denmark and the Netherlands, there's still a very high rate also being diagnosed every year. In the Caribbean, which I know most of you will be interested in, the incidence is 7.5 per 100,000 between the ages of 25 and 29, and a shocking increase as one gets older, 226 per 100,000 between the ages of 50 and 65. Between the ages of 50 and 65, breast cancer is still considered the highest rate, not only in the Caribbean, but globally. But note the difference in incidence with age. Reason for this disease being associated as a postmenopausal woman disease, as it was in the past. Things have changed, however. In Barbados, the incidence to date is fairly low. It is 58.4 per 100,000, lower than world rates and in Africa and America. But PAHO has said that Caribbean countries' incidence rates is not quite accurate due to non-existence of tumor registers in some of the islands. And in BIM, not all positive cases are registered. That is because, as you know, we have a large private sector. And so we don't know how many patients go overseas for biopsies and how many go to the Queen Elizabeth Hospital. And that's where our problem is. We have more to register, but it's not really accurate because of the private sector not registering their cases. Probably when it becomes compulsory, and even if things are compulsory, people might just not fall into it and do it. Now, in the Bahamas, which I find very interesting, it's demoralizing, but it's very interesting and frightening. The incidence is yet to be explained. Between 300 and 500 new cases are being diagnosed per year, with 48% of those diagnosed are below age 50. You see the difference? And an average of about age 42, where most people are being diagnosed. And 44% of Bahamians are stages 3 and 4. That's not what we want. We want to be diagnosing patients with stages 0 to 1. But unfortunately, that is the situation in Bahamas. What is most interesting is the genetic research that in the Bahamian woman, and that has shown that the highest prevalence of the inherited gene BRCA1 and 2, Bahamas have the highest in the world. More and more Bahamian women today of younger age group are coming forward to have bilateral prophylactic mastectomy, that is having their breasts removed, both breasts, and having reconstruction. Some are also opting to have their ovaries removed over the age of 35. This therefore reduces their risk of developing breast and ovarian cancer. You know, the two go together. And this BRCA1 and 2 is a very naughty gene. This mutation is causing so much confusion. And unfortunately, the Bahamian women are suffering because of that. Globally, the incidence, that is the number of new cases, continues to show increases yearly. We have seen this in Barbados. But of course, the more patients you screen, or the more women you screen, by screening, I mean people who have not had any symptoms, the larger the number that you do the tests on, the higher rate you will find. And that's what the incidence increase is all about. And this is why the awareness is so important. So therefore in Barbados, the same pattern exists, but a continuous increase in new cases per year. However, the good news here is this: although the number of newly diagnosed cases are increasing yearly, the percentage mortality, when you compare that with deaths from other cancers, since 2003 has remained between 9 and 11%. Therefore, we must be doing something right. This is one of the most heartwarming things for us on the subcommittee, that, you know, more cases are being diagnosed, but we're not seeing a lot of stage 4. And the objective of this whole program when it started was because we were seeing so many stage 4 breast cancers. If a patient is diagnosed with stage 0 to 1, they have a 98 to 99% chances of 5-year survivor and, you know, a survivor of But when they diagnose a stage 4, the prognosis is completely different. Okay, briefly, what is breast cancer? I don't want to go into too many nitty-gritty details. I gave you those statistics so that you can see why awareness is important and why breast cancer is so important in our lives. Breast cancer is a type of cancer where cells in the breast tissue divide and grow without normal control. It is widespread and a random disease. It is no respect of persons and is the most prevalent cancer in the world today, with about 1.3 million people diagnosed annually. We're talking about COVID, but there you are, 1.3 million every year. That's being diagnosed. The exact cause is still unknown. Currently, there's no cure, but there is hope. Thanks to heightened awareness, which is what we try to do in Barbados, early detection through screening and improved treatment, also to increased access to breast health services, persons have a greater chance of survival than ever before. Survival 5-year rates, there's great improvement in the survival of patients diagnosed with breast cancer beyond 5 years due to increased breast cancer awareness, early detection, and improved treatment. As you know, there's a lot of money being spent globally in finding the best treatment that there is, or actually looking for a cure for this disease. First of all, what is meant by breast cancer awareness, which is what we're doing all the time over the last number of years? That is, persons get to know how their breasts look and feel normally. So whenever there's changes, it will be detected, and it's detected early. So if by chance there's cancer, one will have better treatment options and a better prognosis. Cancer is diagnosed, as I was saying, at stages 0 and 1, has a 99% 5-year survivor when compared with the diagnosis of stage 4, which leaves us with 12 to 15% 5-year survival. Remember, about 85%, and this is something I want to impress upon you, And that's why the awareness is so important. About 85% of breast changes are found by the patients themselves. And I have found from my little experience in Barbadian women that quite a number of those were felt also by the partner. Sometimes the partner feels it and brings it to the attention of the patient. Now, there's a 4-point awareness code. 1, to know the normal. 2, to know what changes to look and feel for. And then 3, to look and feel. And the 4th thing, which is very important, report any changes to your doctor or health provider. And what I'm going to advise you is this. If you feel something or you see something, it was not there 2 months ago or 3 months ago, irrespective of what your doctor says that it's nothing, it was not there, it's new. So it's for you to make sure you attend probably the breast health clinic, which not because I'm involved in it, but it is a very good clinic. The nurses there are supposed to be very good, and they would guide you as to what is the next step. If you feel something, even if she doesn't feel it, we have consultant surgeons there who visit every week. We have 3 of them at the moment, and they'll be able to check you and guide you as what's the next step. Now, because if you know your breast, trust me, nobody can convince you that there's nothing there when you know there's something there. As stated before, breast cancer is a disease where cells in the breast tissue divide and grow without normal control. Now, our bodies are made up of tissues. Tissues are made up of cells. These cells are building blocks of every organ in the body. And every day, cells in the body divide and grow, die in a very controlled and orderly manner. But when they grow out of control, this uncontrolled growth of cells form a mass or lump referred to as a lump or sometimes a tumor in the breast. Tumors may be cancerous, but not all tumors are cancerous or non-cancerous, and the majority are non-cancerous. Cancerous tumors can invade, that's the difference, they can invade its surrounding or the neighboring tissues or spread further to other parts of the body. And tumors that are not cancerous does nothing, but they can increase in size, but they tend not to invade or go anywhere else. Commonly found non-cancerous masses in the breast. This is what I see very often in my office because as a gynecologist, one of the things we were taught in the UK is that a gynecological examination is never complete unless the breast is examined. So it's part of your sexual organs, so we do examine the breast. Fibroadenoma. I'm sure you've heard of this because I hear women talking about this adenoma thing and this fibrosis thing and this fibro thing as they refer to that. Or they might say this cyst, I've got fibrocystic. The most common tumors are the fibroadenomas. They're painless, they're solid, and they vary in sizes and numbers. They're found mainly in the younger females, but can be found in any breast. The cause is unknown, but may be related to reproductive hormones as they tend to shrink after menopause. Because they're solid, biopsies are very often recommended to exclude cancer, which are also solid masses. Now, fibrocystic disease, which is more common and probably in your age group. They can occur at any stage, but most commonly between the ages of 30 to 50. And they tend to resolve after menopause. Not always, but they tend to. These can also vary in size and numbers and in any part of the breast. They are like a cyst, they're filled with fluid and can be painful and tender. Normal hormonal variation during menstrual cycle is the primary contributing factor. So you would hear patients say, oh, every month before my breast gets so tender and so and so. And quite often in those patients, you will find fibrocystic changes. It might be small, but quite often they're there. Treatment includes evening primrose oil, which is popular and used very often, vitamin A and B6. But definitely reduction of caffeine, and chocolates. The chocolate one I have found to be true because very often some of my patients who complain of fibrocystic breast pain, on discussion, I said, how much chocolate do you eat? Well, I just have a little every day, that kind of thing. And, some patients, when they're coming up to their period, they have this desire to have chocolates or sweets. And chocolates tend to cause more of the fibrocystic discomfort. It doesn't actually, I don't think it causes the formation of fibrocystic changes, but it does make the discomfort worse. Now remember, breast cancer is no respecter of persons. No one is excluded. It affects all races, religion, social classes. What used to be thought of as a postmenopausal woman disease is no longer so. Even though the highest incidence is between ages 50 to 65, today, globally, females as young as late teens have been diagnosed positive. So all we can do is to be aware and be vigilant. What causes breast cancer? We all know the exact cause is still unknown. But 5 to 8% of women who develop breast cancer have been known to have a genetic predisposition, as I was saying, is BRCA1 and 2 or 2, a mutation gene, which have been found in these persons, giving them a twofold increased risk of developing the disease. By that I mean, if you have in your gene this mutation of BRCA1 or 2, your chances or your risk of getting breast cancer is twofold. This is why some people, when they have the gene, have their breast removed. And when you do that, you're reducing 75% of your risk. But we have to explain the other 92 to 95% of patients who develop this disease. There's some identified risk. I'll quickly run through those. By that, I mean people who have a more likely risk of developing the disease. I know some of this will shock you, but research has shown that they are relevant. Of course, the highest risk of developing breast cancer is being a female. Men do get breast cancer, but it's less than 1%. Increasing age, we've done that before. 80% of breast cancer occur over age 50. Early age of beginning menstruation. If you begin your menstruation before age 11, you're at higher risk, or your risk is increased. Late onset of menopause. Menopause after the age of 55 is considered an added risk. History of previous breast cancer. Of course, if you had a history of previous cancer, you have a risk of getting recurrence. History of certain non-cancer breast problems. There's a particular one called atypical breast hyperplasia. This is only diagnosed on biopsy, and that presents with a tumor or a little lump in the breast. History of no children or late childbearing. Having your first child after age 30 years increases the risk. That is what they mean by late childbearing. The more children a woman has, slightly reduces her risk of developing the disease. And when she has no children, if she's never had any children, her risk is increased. From this, you can deduct that there has to be a hormonal influence on breast cancer. Now, breastfeeding. Some research has shown breastfeeding helps to protect against the disease. And the longer a person breastfeeds her children, the less likely she has of developing breast cancer. However, not enough research has been done on this because, today women they don't breastfeed for long. Now, hormone replacement therapy, especially used over 5 years. A family history of breast cancer, ovarian cancer, and now prostate cancer has been added to that list because they found that males with prostate cancer sometimes have the presence of that same gene, BRCA1 or 2. And of course, cigarette. Nicotine has been a carcinogenic agent from way back when. I know what would surprise you is the fact that as you defer pregnancy into, and I know that today a woman wants to do that, and I don't blame them. We live in a matriarchal society, and you would want to have your university education or the highest you can get, then you want to have a home to put the child. You want to have a steady relationship and then have the baby. I mean, honestly, I can't blame you for that. And I have patients in my office in their 40s pregnant. And, I don't fuss about it. I just have to take more care of them because they do have a little more risk where the pregnancy is concerned. So, as I did mention to you before, men can get breast cancer. Less than 1%. But in the UK, that's the only place I got the statistics from. An average of about 300 men are diagnosed in the UK every year. There's some risk for men. One, age. Older men seem to be at a greater risk. Family history. If there's a family history of breast cancer or close female relative with the disease. And of course, that inherited gene mutation. And then estrogen therapy. Now, estrogen is used sometimes for prostate cancer. And patients are advised that if they're on treatment for the prostate cancer with estrogen, they need to be vigilant and check the breast because they can develop breast cancer. And cirrhosis of the liver is one of the other predisposing factors. Now, there's some myths about breast cancer, and I need to just clearly clarify some of these. One of the big things is deodorants, and this took, it went off in Barbados for a number of years about aluminum in the deodorant and one thing or another. But to date, there's no hard evidence to prove or disapprove this myth, which has caused unnecessary distress to a number of women. Today, some women don't even want to use deodorant because they're afraid of this. But there's been no any research that has proved. Underwired bras. Now, there's no evidence to date to support this either. Major stress relationship to breast cancer. Well, there's no hard evidence to date that being stressed increases your risk. More research is needed to establish any link. However, a few studies have associated emotional stress, such as ones that are uncontrollable. For instance, difficult divorce, or dealing with children or partners that are addicted to alcohol or drugs. There's done quite a bit of research in this in the United States, and they have found that women in these situations tend to have a higher risk. Now, bruising of the breast tissue. Now, that's a myth too. Not enough evidence that injury or trauma to the breast causes or increases the risk. It can, however, cause some changes when you're interpreting a mammogram. So very often when we're writing up the request form, if this patient has had some bruising or she's had an accident, and so you make a note of that. So when the radiologist is reading the mammogram, he will know what to look for. Because sometimes with trauma, the fat in the breast undergo necrosis because the trauma causes bruising and disturbance of blood supply. So the tissue that was traumatized can undergo necrosis, and that can sometimes form a little lump. But the radiologist is able to identify whether it's necrosis of the breast tissue or if it is anything growing there. Excuse me. Breast pain. Does that mean breast cancer? No. Breast cancer can be totally painless, and it is so most times. Breast pain, however, or mastalgia is quite common. About two-thirds of premenopausal women will experience some degree of breast pain during their lives. Breast pain very often is cyclical. As I said before, it's related to your menstrual cycle, but can be non-cyclical and does not mean breast cancer is present, particularly if you have fibrocystic breast disease. Pregnancy increases the risk? No, the opposite. Pregnancy reduces the risk. The more, as I mentioned before, the more pregnancies you have, the lower your risk is. Now we go on to early detection of breast cancer, which is very important because this is what saves lives. And it is important for all of us to know that early detection is the number one in our lives, okay? I know some years ago I had a difficult time trying to convince a particular surgeon at Queen Elizabeth that it is important that women be vigilant and check their breasts. I even remember the forum saying that, but you know, 85 to 86% of these changes are found by the patients. So what is your problem with patients examining the breast? You know what was his defense? Oh, they get so anxious when they find something that, you know, they lose their sleep. And I said, okay, that's only a temporary thing, but it can save their life. But anyway, I had support at the forum by a lot of women who were there that yes, we have to do that. Anyway, breast self-examination, which is number one. At the breastfeeding program, we follow the protocols of the American Cancer Society. And it has done as well. Breast self-examination, which I'm going to show you with the model, and that's to be done monthly or even every 2 months, but try to do it. Beginning when? Beginning in adolescence. In your teens, about age 15, 16, and this has two benefits. The young lady or the adolescent is able to find any changes if there's any, and not only that, she's able to teach her mom and teach her granny that this is how you do it and this is what you look for, okay? The second thing is yearly clinical breast examination by your physician or health provider. Whenever you go for your pap smears, or even if you're going for a chest infection or you're going for something, a gynecological thing, please say to your physician, please check my breast. Try and do that every year, okay? The third thing is your mammogram screening, and that is to be done yearly, starting at age 40 or earlier if there's a family history or breast cancer or ovarian cancer, and continuing every 1 to 2 years until age 50. After age 50, because the incidence increases, we advise you to do it yearly. I have a problem with this one eye. Okay, now the role of mammogram, ultrasound, and MRI in screening for breast cancer. Ultrasound and MRI complements mammogram, but are not substitutes for mammogram. They're not substitutes for mammogram. To today, 2020 October, mammograms are still the gold standard. Both techniques are useful for women of any age who have mammographically dense breast tissue, in which lesions may be obscure, or for whom the nature of a mammogram density, solid or cystic, cannot be determined. The decision about whether ultrasound should be added to mammogram is made by the consultant radiologist. Radiologist is the person who is a specialist in reading the mammograms. Person reading the mammogram is very important. And what we have at the breastfeeding program are consultant radiologists. We have one who's an interventional consultant radiologist, and we have another radiologist, not a radiographer. There's a difference. The radiographer is the technician who takes the mammograms, who does the pictures, who puts the breast on the machine. But the person that reads the mammograms and interprets it is the radiologist. And the interventional radiologist is somebody who will do the biopsies using the mammogram or using the ultrasound. And we have all of these at the breastfeeding program in Henry Lane. So the decision about whether an ultrasound should be added to a mammogram is made by the consultant radiologist. Now, mammograms have remained the gold standard, as I said before, for early detection over the years and has continued to be the best for early detection. At the breastfeeding program, we have been very fortunate in being able to continually upgrade the equipment in keeping with global changes. Funds raised from the walk goes towards the purchase of all equipment and their maintenance. This is why we've been able to buy the best that there is. At the clinic, we are fortunate to have access to continuous upgrading of imaging technology, state-of-the-art 3D ultrasound machine. What we have at the moment is 2D mammogram machine, which is the digital direct, and it's the only one in the island. But we are hoping to get the 3D mammogram machine, which is called the tomogram or tomosynthesis machine. We have the funds. We raised it over the last 2 years from the walk and from donations. And we're just awaiting an area to accommodate it in the breast clinic. Hopefully, this should be done in 2021 and early 21. Now, this upgrade is valued at almost $1 million and is graded as state-of-the-art in first world countries. I've seen this myself on 2 or 3 conferences that I've gone to. I'm very impressed. To me, it's almost like a mammogram and an ultrasound combined, because the technician moves this machine all over the breast like this, the way you do it with an ultrasound probe. In Barbados, we're fortunate again to have a one-stop early detection clinic at the breastfeeding program, with state-of-the-art equipment operated by, as I said before, skilled professionals, and all services are at affordable cost to the public. The services include breast examinations and teaching of breast self-exam. Whenever you go for a mammogram, there's a nurse there who will teach you how to examine your breast and examine your breast. Ultrasounds, breast biopsies, and we also have an operating theater with non-interventional facilities. It is hoped that with continuous island-wide education and awareness of the disease, continued vigilance, and response to the screening program for early detection, the number of deaths from breast cancer in our island will continue to fall. Because remember, we're not seeing stage 4 and stage 5 like we used to when this program started. Ladies, until the exact cause of this disease and a cure for it is found, early detection is still your best protection. You owe it to yourselves, your family, to ensure that there's early detection if you do develop this cancer, because the good news is there is life after breast cancer. Wouldn't it be wonderful to live in a world without breast cancer? Thank you. I hope you've had loads of questions that I'll try to answer them. But what I want to do next is I need a little bit of help from my receptionist to put the model on so I can demonstrate you firsthand how to do this breast examination. The first thing you do is look. Remember, it's look and feel. Look in the mirror. Put your hands up above your head. Okay? Look at the side. Look in front. Look at the side. Look in front. What are you looking for? You might be able to see a little bump. You might see blue vessels. You might see a red area. You might see puckering. Okay? You will see it in one side and you don't see it in the other. Remember that. Whatever is in one side must be in the other side. Okay, next thing. You feel. You use this part of your fingers, okay, because that's most sensitive. The pulps of the 3 fingers, okay? And that's what you're going to use. Now, the different ways of doing it. This is feel now, okay? You can start from wherever you want to. Now, if you're examining the left breast, you put that left hand above your head and you use your right hand, okay? And you go around. You can do it several ways. You can go around like this, okay? Just pressing. Then you come near the nipple and you go around again. And then when you get to the nipple, you use this finger here and you just gently squeeze and see what comes out of it. Remember, if you see blood, if you see anything other than milk or clear fluid, you have to have it checked. Good. Then you go to the other side and you do the same thing. Then the last thing you do is put your fingers, the same fingers, under your arm into the axilla, way up at the top, and see if you feel a little lump or a swelling or anything there. Basically, that's it. Secret is whatever is in one side must be in the other. So when you're examining this one, you put that hand above your head, because what that does, that tightens the muscle underneath. So all you're feeling now is breast tissue. Then you do it the same to the other side. Good? Right. Ready for the questions.
Thank you so much, Dr. Jhagroo.
You're welcome.
I'm going to wait for, that was a really, really good presentation. Gosh, I have so many questions.
Oh dear.
I'm not seeing it. I'm not seeing any yet coming from the participants.
That means they understood it all, right?
Yes, yes. The one thing I think maybe you could start with early up in your presentation.
Uh-huh.
I was kind of doing some letting in people and I missed something. You were giving some a demographic outline of women who have been diagnosed with breast cancer. I wasn't sure if that was in Barbados or globally. So if
Oh,
maybe you can do that kind of demographic sketch of
not
breast cancer.
not the one in Bahamas, is it?
No, no, no. It was before
Okay.
that. It was before that.
Um, would that be the United States?
I can't recall, but you were into
Okay.
race. Race was mentioned.
Oh yes.
So
Okay,
probably it was
probably.
the
Yeah, but
US.
okay. It wasn't. Well, no. We do know that in Europe, in Belgium, and those places, that the incidence is high. Okay.
Mm-hmm.
Now we also know that in the United States, the incidence is higher in the white population than in the black population.
Okay.
But
Yes, I got it.
the survival rates is higher in the white population because the black population do not have the access to all
Right.
that can be done for them. You know, by the time they're seen, it's late. Well, it's later, you know. And once you come to stage 3 and 4, your prognosis falls.
Yeah, I wanted to get to that. Thank you so much for that. But I was wondering if you had any kind of demographic sketch for Barbados. I think mentioned the ages for Barbadian women when they were first detected. I think we do have a question from the floor, but I just wanted to ask that question when they are first detected with breast cancer. I know you said the ages changed over the years. You're
Yes.
seeing
Okay.
now
Right.
younger women.
Good
But I'm just
question.
wondering
Yeah.
if for Barbados, if you have that
Yeah.
kind of demographic.
But we haven't
Mhm.
got what they have in Bahamas. Thank God, because I wouldn't know how to start to help. But in Barbados, we have found that most of the cases used to be between the ages of 50 and 65. Okay.
Mhm.
But now we're seeing younger women. The percentage of women seen below the age of 45 with breast cancer is increasing. Now, it could be due to two things. One, patients are coming, they're being the awareness. So they're coming
Right.
forward earlier.
Yeah.
They're checking.
Mhm.
And so therefore, the more people you check, the higher will be your incidence. And the good
Right.
thing about all this in Barbados is this, you know, most of our women are stages 0 to 1. This is why we keep working in this program, because we're seeing results.
Right. You said that. Can I ask a question, Dr. Jhagroo? Because I'm watching the time and it is 1:30. Would you mind if you go over 2 more minutes, Dr.
No,
Jhagroo? You have two more
no, no,
minutes?
no, no.
Okay, excellent. You mentioned the different stages of breast cancer, and would you be able to say more about, so you spoke about stage 1, 0 to 1, and then stage 4. Can you say a little bit more about each of these stages so that women would have an understanding, or at least the participants here would have an understanding of what they are and what they entail?
Well, okay, stage 0, but you've got different classification of stages. You know, where the clinical classification. I don't want to go into too much detail. The
Okay,
clinical one,
yes.
and then what the lab tells you. You know,
Right.
basically. Now, when you stage 0, which is what we're hoping to find with everybody, something below 1 centimeter in
Okay.
size. Okay, it might not be palpable. It might just be seen with the mammogram. And that's the beauty of a good mammogram machine. The direct digital very often is looking for what's called microcalcification. And you can just see two, and very often those things are not even palpable, but is found, is detected by the mammo machine. And then stage 1, when it's more than the 1 centimeter, that's clinically. And then stage 2, if there's a gland involved and it's larger than 1 centimeter. And then stage 3, when it starts to invade other tissues, it can be just the breast tissue itself, or it's gone into lymph nodes and it's gone under the arm, which is usually the first place. And then stage 4 is when it's gone to other parts of the body. That's basically it, you know.
Okay. Yeah,
But
that's very helpful. Thank
in
you.
2000, in 1999, when we were trying to put this program together, I'll tell you something. All the patients I saw, more or less, well, I wouldn't say all, but more than 90% had stage 4, you know. And there was this stigma attached to it. And
Right.
people
I
would
wanted to
hide
ask
and
about
they
that.
wouldn't go. They wouldn't, they just hid because they look, it's a death sentence. So there's no point. So they hid, poor things. And because I saw this, I brought it to attention of a very good friend, Arthur, Beverly Arthur. We were buddies because she worked with me as my nurse at QE.
Mm-hmm.
I said, let's try and do something. It started just like that. Let's try and do something. What can we do? We had a meeting at the Old Hilton, and we invited a representative of all the women groups on the island, and everyone. It was sponsored by Collins Limited, Peter Bourne. Almost everyone, yes, let's do something. And that's how it started. And now the stigma is gone, huh? Women are going for, you see them on the television, on the radio.
Yes,
In the
I actually heard one on the radio
talking about
just
it.
before today. Yes,
and
talking.
Because they're talking about it and they're alive, their whole thing is you can be alive too if you do the various things. Early detection.
There was thank you so much for that, Dr. Jhagroo. There's also coming across quite a few concerns with the radiation from the mammogram versus the ultrasound and that kind of discourse that has been going on. I'm wondering, because you're saying that mammogram is a gold star, but then I'm hearing otherwise. So maybe you can explain a little bit more. I'll just share one thing first. I remember I went for my mammogram and it was under 12 months and the radiographer quarreled with me for coming too soon to get it done because of the possibility of being exposed. So maybe you can explain a little bit about
First
that.
First of all, I'll tell you the digital mammogram, which is the one we have, which is the 2D. That mammogram became very popular because the amount of radiation you get from it is no more than when you're having your tooth x-rayed. If you have to do extra films, like women with large breasts, they get a little more exposure because you have to take different views.
Okay.
Right? The benefit of this other machine that we're getting called the tomogram, it can take large breasts with one go.
Okay.
Excuse me? So that's the benefit. But the amount of radiation is very minimal. But you don't want to expose anybody to radiation unless it's necessary. Now that's the mammogram. And mammogram can show, and once you see it, you know that that's breast cancer. The tiniest calcification, which is called microcalcification. And you can see them in little clusters. And that's what you're looking for. It's specific. I mean, as soon as you see it, you know it. Now, compare that with an ultrasound. An ultrasound will actually, it works with sound waves. It's safe. You can have a lot of ultrasounds. I mean, we do it on babies, we do it on fetuses. It's harmless as far as we know. And the ultrasound can differentiate if something that's in the breast is solid or if it has fluid in it. And that gives you a good guide. The shape of the wall, of the outline of that thing, of that tumor or mass or whatever that you're seeing with the ultrasound gives you a good guide. The shape of it, the density of it, all those things will tell you that this is something that you need to do a biopsy on. So that's why we do biopsies on most of the solid ones, because the ultrasound can't tell you much more except that it's solid. So sometimes a fibroadenoma, which I mentioned before, which is quite common, we end up doing a lot of biopsies on them because they're solid. And we have to make sure that we're not missing a cancer.
Right. Okay.
And the other thing is women with very dense breast tissue, which is due to your hormones. I mean, look at you. You're very good looking. You got beautiful skin. Your estrogen level is good. And I know mine is good because I'm 79 and my skin is flawless. And I know but I'm a breast cancer risk because of that. I know my estrogens are good. Okay. So what happens to these women with dense breast tissue? I still have at my age. I have to do mammogram and ultrasound.
Right. Okay.
Because if the mammogram, you can't see through it. What happened over the years is this. The old mammogram machines used a lot of radiation, right? So that you can see through the breast tissue. With advent of new technology, the they use less and less radiation to see through as much of the breast tissue as possible. So this
So
is
some
why we have these new technology, new mammogram machines that use less and less radiation.
So some of the fears could have been retention from the analog mammograms that had a significant amount of radiation
Yes,
that
yes, yeah. The
that
older
just
mammogram
got a
machines,
bad rep
there
and
was, yeah.
everybody okay.
And that's why, and over trying to reduce that, we end up now not being able to see through young women's breasts because it can't see through the dense breast. There's not enough
Right.
radiation going through.
Right. Thank you so much. And I think just my last question, although I have several, and mind you, I came with lots of questions, right?
We have one
Um,
from our participants. In
oh,
your
well,
first.
I'll let them go and then I'll close with my question. Go ahead.
Okay.
Kelia.
This person is asking, I have heard that diet has a strong relation with breast cancer, particularly certain products such as dairy milk. You have mentioned chocolate in your presentation. Can you offer some clarity on the correlation between breast cancer and chocolate? Is all types of chocolate bad? I have heard that dark chocolate is healthier. Disclaimer, she's a chocoholic. Also, she wants to know at what
But
age
let me tell you
did you
something.
have your first
A
test?
lot of women are chocoholics, so don't worry. You're just joining them. Well, no, a lot of research has been done lately and studies on dark chocolate being better than milk chocolate. I really don't know. I'm not 100% convinced, but it doesn't make that much difference to your cholesterol. So it's supposed to be healthier. There's studies being done on all that, okay? But I do know that soya is supposed to contain quite a bit of estrogen. And that's my concern about people drinking soy milk and eating a lot of vegetarians using soy for in place of meat. And
Correct.
eating a lot, everything in moderation, but they use soy a lot.
Yeah.
And I am concerned about that because we don't want to add estrogen to your diet,
Correct.
whatever you do. Because we do know that there's an association between estrogen and breast cancer.
Mhm.
So the more we stay away from the estrogen, the better. I mean, even today, when I put people on hormone replacement therapy because they're having all these menopausal symptoms, I say to them, okay, 3 months, right? And then we're going to wean you off. And then we're going to, that kind of thing. I'm afraid to do it. I'm kind of cautious. When I came back from the UK in the 70s, all those women over 70 who were not having sex because of dry vagina, because, all kinds of things. I found a Barbadian public used to say, at 50, I'm done with that. I said, why? I don't have the urge. So I used to putting them on the HRT because when I left UK, we were doing that. And then up came this and that about the HRT. And I thought, oh my God, So, but we do know now that if you're in those things for more than 5 years, your risk increasing. And the same thing with soy products. So diet is,
Correct.
To that extent is related, but not a lot of things. And I wouldn't say the chocolate is going to increase your risk of breast cancer. No, but everything in moderation. That's life, Everything in moderation. The alcohol, the wine we drink, all these things, coffee. But postmenopausal women, they don't do very well with hot flushes and all that if they take caffeine.
Okay.
Green tea with caffeine and these things, they don't do it because they have more flushes.
Okay. Monique, I have 2 more questions. Can I go or are you going to wrap up now?
Well, it is going quarter to us, so maybe we can take them and then if we can get the answers and email them.
Cool.
Yeah.
No
Because it's
problem.
over
I'm
time.
all right. I'm all right for time,
Okay.
I sort
Okay,
of
well, go
left it.
ahead, Kelia, then. Go ahead then, Kelia.
Okay. With breast cancer being detected earlier in some women, at what age should a person get their first test?
The first mammogram.
Yes.
Yeah, well, what I
With
said, I did say that we followed the American Cancer Society protocols, and we started age 40. Now, people always say, why? And I said, it's arbitrary, but why we do this is because they have chosen an age where they're expecting that the breast tissue wouldn't be as dense. So we might benefit from mammograms. But that doesn't hold fast for everybody, because sometimes you see people at 40, 42, and the breast tissue is still very dense. You see people like me at 79 with very dense breast tissue, you know, that kind of thing happens. But then you have others that at 40, 42, the breast tissue has quite a bit of fat and very little dense tissue. So mammograms would be beneficial. There's no point doing it at 34-year-old, 32-year-old, and you can't see anything. That's radiation used unnecessarily. In those cases, what we do, if we're concerned about anything, we would do an ultrasound. And if you have a good ultrasoundist for the breast, and this is why actually we used to bring in somebody until recently, an ultrasound is as good as the person reading it, you know. It's what they interpret in that ultrasound.
Yeah.
And that's very important. So for the younger ones, we might do the mammogram depending, and we'll always do an ultrasound and rely on the person reading the ultrasound because they read at the same time. Huh? And we never question if she says she wants to do biopsy, by all means. And the other thing I should have mentioned to you is that the clinic, one of the things about the clinic is that everybody's welcome, whether you have money or you don't have money, whether you can meet the cost or you can't meet the cost, it's fine. We let you come because we're not going to turn you away. We will do it irrespective of you not having the funds. And that's what's happening now because, you know, polyclinic can't see everybody and that kind of thing. So we see them.
Yeah, that's very good because I came and I'm under that age, but when I came, they actually, the nurse on call gave me step by step how to do self-examination and so on.
Yeah.
So it was helpful. Although I wasn't able to do a mammogram or ultrasound, I was able to get some insight as to how to do it properly and that
Right.
type of thing. So
And then
it's
there are
still
doctors
excellent.
there, there are consultant surgeons there. So if they find anything, they always say, well, you have to need to come and see them, you know?
Yeah. Okay.
Oh,
So
great.
the last question from our participants, if one areola is a lot bigger than the other, is that considered normal?
Well, how long has it been so? Has it always been so? That's the question you have to say. Sometimes one breast is bigger than the other. Sometimes the shape of one breast is different from the other. And if one area, sometimes you get an inverted nipple in one and not in the other. How long has it been so? Has it been so since you was a child, an adolescent? Is it sudden? If it's a change, if it's something new, you need to check it. I mean, because just below the areola might be something that's causing it to look bigger. You know what I mean? So you need to have that checked. If it's something new, definitely has to have it checked.
I guess that's where your 4-point comes in, where you know your breast, you check and feel, and
Yes,
Yeah.
all those
yes.
things. So everyone
Yeah.
needs
That's
to.
why I say to you,
be
it doesn't
aware.
matter who say what to you, you insist. Because you know that 18-year-old that we had so many years ago, do you know she went to 4 different people and they all said, you're too young, can't be breast cancer. And just by chance, you know, it was just my housekeeper who said something. And I said, well, it's highly unlikely, but let me see her. Yes, but she's still alive, huh? She's in the States and she's done really well. She had bilateral mastectomy, but she's done very well.
Wow.
But she'd gone to 4 different people and they all told her the same thing, she was too young. So, but you know what we wanted to do too was to take the program to the schools. But to get Ministry of Education to bend, it wasn't easy. So, you know, it was left
Oh,
hanging.
boy.
But I'd love that. I'd love us to be able to get nurses to go to the schools and teach the youth, adolescents, breast self-examination. Because there's a lot of benefit from that. They'll teach their mother and teach their granny, you know.
Yeah, I picked up on that towards the end when you mentioned it in your presentation, breast health literacy, which I think it would be so important to include in the schools. And I
Start from
wondered,
young, anything like that.
wondered about that. Yeah. I think my last question, Kelly, is that it? For questions?
The young lady responded to say from adolescence, as I got older, was more noticeable. In
What
response
same
to the
person?
question before.
Oh, with the
Oh, sorry.
areola. Yeah,
Yeah.
larger areola.
It was
Yeah.
there from adolescence as she got older. Yeah, it was.
They got more noticeable. And she's currently 22.
Well, if it has been there, but she'd still check it.
Okay.
She'd still have it checked for her peace of mind and for
Yeah.
everybody else's peace of mind. You know, she can just go down
Great.
to the breast clinic, the Cancer Society, and say, you know, she's a little bit concerned about this, and the nurses, they're very good. They will review
Awesome,
it.
Monique. Over to you, but Dr. Jhagroo, before you go, just share where you're located and your number, so that those that would want to visit the clinic can do so.
Oh yeah, good call.
Okay. It's near to St. Gabriel's School, where Purity Bakery is. It's not me. I mean, the Cancer Society is there. I'm here. I'm just a volunteer. But it's in Henry Lane, next door to St. Gabriel's School. You can't miss it. And to get there, you turn down at Purity off Collymore Rock, and straight down to the bottom is a dead end. And Cancer Society is just beside St. Gabriel's.
And the telephone number? Do you know how the telephone number?
Yes, 228-0027.
228-0027.
Or 436-8888.
Excellent. Thank you so much for that. And I think that my last question would be just going back on your advocacy, because you've been doing so much advocacy over the years and really bringing awareness, and I think it was 2000, I think I saw, was it the program, the breast screening program, when it started?
2002, we launched in June 2002.
Right.
But it was, we were planning since 1999. Took a few years to get there.
With all the walks, and we see this gotten really good responses. Of course, this year with COVID kind of changed things. But what would be your call for action at the state level and the community level for getting women out to getting more women out to get tested? So at the state level, what would you say should be their involvement? And at community levels, what can be done at community levels to get the awareness out and support?
Well, the thing is, my feeling about something like this is we can't leave everything to government.
No,
okay?
Right.
And it's something that so far the NGO has been able to manage, and I think manage fairly well. It doesn't have all the red tapes. You don't have to get approval of this and approval for that. Those things can be very disheartening, because sometimes it's one step forward and 10 back. And that you don't have, it takes away that enthusiasm. And if somebody like me who's a go-getter, it's hard to cope. It's hard to cope with that. So, but anytime we need support from the government, I'm quite mouthy. I will just go and say, I mean, like we get our t-shirts in duty free, we get all our equipment in duty free, and
excellent.
I just go and ask, and to be honest, they've been very good. Our present Prime Minister, Ryan Strong, all these people have always been with us, and even when they were in opposition, they have kept in touch. So from that point of view, I think we've done. Now with community, I should have mentioned that we have a vehicle, a mobile vehicle.
Yes, we brought it on campus last year.
Yeah.
We had our first breast screening. Yeah, for UWIHARP.
It goes out into the community. And the nurse is supposed to teach women and men, whoever come, how to do the breast examination. So that's our community involvement.
Excellent. Well, thank you so much. I think we can wrap up there, although, I'm an interviewer, so I like to ask a lot of questions. Oral history interviewer. So I like to get into the history and how we got to where we are. But I think we're going to leave it there for today. And I want to thank you so much for such a fabulous presentation and talk today, Dr. Jhagroo.
I'm glad you enjoyed it.
Yes, and thank you.
But you know what? I should tell you too. That building that we're occupying, that's a government building, We got it. It was in shambles, and we refurbished, and we now have it at a peppercorn rent. So, and it was this government that was there in 2000.
Okay.
And so we do get the support, and we get support from corporate Barbados, because for instance, this new machine we're buying is $1 million.
Yes.
And the one we have at the moment was 1.3 million. So, we don't get money from government, but we get the things in duty free. And they help us to do whatever we need help with.
Okay, great. That's really encouraging. And I want to thank the participants, everybody that came today and that stayed on with us. And also thank you to Kelia for providing the support needed to run the webinar today.